Neurology Quiz number 101. Describe the etiology, clinical features, and management of immune-mediated necrotizing myopathy, or IMNM. IMNM is a subgroup of inflammatory myopathy characterized by myofiber necrosis, minimal inflammatory infiltrates on muscle biopsy, markedly elevated creatine kinase levels, and infrequent extramuscular involvement. It is of the following types: HMGCR antibody positive, SRP antibody positive, anti-mitochondrial antibody positive, which is rare, and 30 to 35% of the cases are antibody negative. Anti-HMGCR myopathy is the most common, and the majority of patients with this disorder have a history of exposure to statins. However, it is rare among statin users, and at least 30% of the patients are statin naive. This indicates that there are additional susceptibility factors that trigger antibody production. Anti-SRP antibody syndrome is the most severe and is characterized by marked and rapidly progressive weakness in very high CPK levels, usually in the 5 digits. It has a seasonal predilection occurring mostly in the fall. Anti-mitochondrial antibody-related myositis manifests as IMNM in more than 50% of the cases and less often as granulomatous myositis. Clinical features: the autoimmune inflammatory myopathies are rare with a prevalence of 9 to 14 per 100,000, and about 10% are positive for anti-SRP or anti-HMGCR antibody. Patients develop proximal weakness that may occur acutely or subacutely and is frequently severe. Anti-SRP IMNM is more common in women and is one of the most severe inflammatory myopathies. Dysphagia is present in roughly half of the patients at the time of diagnosis. Cases of cardiac involvement in association with anti-SRP myositis have been reported. These patients may develop respiratory failure due to diaphragmatic weakness. Interstitial lung disease occurs in 10 to 20% of patients with anti-SRP myopathy and less than 5% of those with anti-HMGCR myopathy. 20% of patients with anti-mitochondrial antibody myositis have primary biliary cirrhosis. In general, significant skin or lung involvement should suggest the possibility of another type of inflammatory myopathy. In children, anti-SRP and anti-HMGCR myopathy may present with slowly progressive proximal muscle weakness that can be difficult to differentiate clinically from a limb-girdle muscle dystrophy. Therefore, it is essential to test for these antibodies in children thought to have muscular dystrophy but who have no family history or genetically confirmed diagnosis. Antibody negative IMNM remains poorly characterized. A notable feature of the antibody negative group is increased risk of associated malignancy. Cancer risk. In IMNM, cancer risk depends on the disease subtype. Antibody-negative IMNM has been associated with a significant increase in risk of malignancy. Aggressive cancer screening for up to 3 years from the onset of symptoms is warranted in these patients. Anti-HMGCR myopathy may have a relatively weak association with cancer. Anti-SRP myopathy is not associated with cancer. Investigations. CPK. Patients with IMNM have the greatest muscle enzyme elevations among those with various types of myositis. Typically, CPK is markedly elevated up to several thousand, and the median peak is reported as 4700. CK elevations may precede the onset of weakness and can be used to detect exacerbations of disease when therapy is being weaned. CK can normalize in spite of ongoing disease activity in patients with long-standing disease due to replacement of muscle by fat. Muscle biopsy. This is characterized by the presence of necrosis of muscle fibers or regeneration with the paucity of lymphocytic infiltrates. Perivascular inflammation and perivascular atrophy, which are features seen in other inflammatory myopathies, do not occur. EMG. EMG shows a myopathic motor unit potential with muscle membrane irritability. Abnormal spontaneous activity is seen in the form of positive sharp waves, fibrillation potentials, complex repetitive discharges, and even pseudomyotonia. Here the figure shows a muscle biopsy from a patient with IMNM. In A, there are numerous scattered necrotic muscle fibers and a few regenerating fibers and no inflammatory exudate. And in B, there are macrophages invading necrotic fibers which appear red with an acid phosphatase stain. This figure shows light microscopy findings in IMNM with an H&D stain. There are a few scattered necrotic and regenerating fibers seen without any inflammatory exudate. MRI, patients with IMNM show generalized muscle edema seen as hyperintensities on stir images that are associated with ongoing inflammation and necrosis. There is relatively less involvement of the anterior compartment. Atrophy and fatty infiltration on T1 weighted images appears later in the disease. In contrast to patients with dermatomyositis, there is minimal fascial edema. Patients with anti-SRP myopathy reveal higher rates of fatty replacement and atrophy, indicating a more severe form of myositis. This figure shows MRI in IMNM with T1 weighted and stir MRI images showing edema, atrophy, and fatty replacement in the disease. This is another figure showing MRI appearance in IMNM. These are MRI T2 images which are axial and coronal as well as sagittal, showing hyperintensity of the adductor muscles of both thighs as well as the hamstring muscles of the left thigh. Treatment: there are no RCTs to guide treatment, and it is based on observational studies and consensus of expert opinion. Number 1, corticosteroids. Steroids are usually first-line agents due to their rapid efficacy. A dose of 1 mg per kilogram per day of prednisone, 60 to 80 milligrams, is the typical starting dose. IV methylprednisolone can be given initially, followed by oral prednisone in patients with severe or rapidly progressive weakness. Prednisone tapering typically should not begin before 4 to 6 weeks and should be individualized based on clinical assessment once patients have shown significant improvement. To reduce the risk of relapse, a very slow taper is recommended. Clinical evaluation should be performed before each taper, and tapering should be halted if subtle signs of worsening appear. Steroid-sparing agents. A second immunosuppressive should be started early in the course. For inflammatory muscle disease as a group, these agents include methotrexate, azathioprine, mycophenolate mofetil or IVIG. Evidence suggests that IVIG is especially effective in anti-HMGCR myositis, even as monotherapy, and should be preferred in such patients. Rituximab, which is used in refractory dermatomyositis and anti-synthetase syndrome, has been shown to be effective in anti-SRP myositis. Its early use is favored in these patients, and this is recommended in the European Neuromuscular Center guidelines. Prognosis: IMNM can be disabling and difficult to treat. In some studies, only half the patients with anti-SRP disease achieved normal or near normal strength even after 4 years of treatment, with similar results in anti-HMGCR patients after 2 years. Young age of onset is a poor prognostic factor, and aggressive combination therapy is recommended. Steroid monotherapy should be avoided in such patients, as this is usually not sufficient to adequately control disease activity or prevent further damage. Anti-SRP myositis is more likely to be severe and cause muscle atrophy and fatty replacement with significant residual weakness.